So I want to start by just having you introduce yourself and tell us a little bit about you, what you do, and how you came across this idea of studying fasting for your Muslim diabetic patients.
My name is Joyce Lee. I am a clinical pharmacist, and I am also a lecturer at the National University of Singapore when this study took place. I originally am from California, but after my studies, I decided to take to work overseas. So I worked in Singapore, and when I start working in that environment, I've noticed that the patient population is just very, very different. I encountered people with different religious background, and Singapore being a very diverse, multi-ethnic, the way how it's being made up, with the Chinese and Malays and Indians being the most common three ethnic groups there. People are also very diverse in terms of their cultural practices and their religion. So I encounter a few patients who actually fast during Ramadan, and sometimes, they come to me and then they will say that, so my doctor told me not to fast. So what should I do with my medication? So they would ask me questions like that. Then, we actually have a collaborative care. So that sometimes brings up a question to me of, what exactly is going on with this group of patients. So the reason that we really felt that this particular algorithm is important, mainly because we found out that there's a miscommunication, and also I think the healthcare professionals and the patients are really not communicating. Sometimes depending on the level of exposure, the healthcare professionals may not feel comfortable looking after this group of patients who are very devoted in their religion. And sometimes it's also because the patients themselves are just not stable, so that they're not really qualified to fast because it might be more dangerous to them. And but sometimes it's just simply because there's not enough exposure to take care of this type of patients. So there's a lot of components to why we decided to come up with this particular algorithm. And I think one thing that's most important is really the empowerment that is lacking with current practice, where a lot of times we practice with, it's more like a one-size-fits-all. But we feel that we need to have a tool that is actually more religiously sensitive, and we should be able to help our patients, if they really want to fast, is there a way that we can help them to fast safely? So that's how we really started it. And it starts all the way back in 2012 when we start to do a few prospective and also retrospective studies just to look at our own patient population. And we noticed that initially we did a retrospective of about 5,000 patients, and we just want to see if there's any changes with their blood glucose. And indeed, we found something that's very interesting. We saw that the blood glucose actually improves during Ramadan. And this is really without any intervention. We just look at their data. And we also want to see the change in blood pressure and also cholesterol. But they were not very, there's not much of a difference in terms of cholesterol or blood pressure. But in terms of glucose, we definitely see the changes. And so what we did is we went on and we did a prospective study of 150 patients, and where we administered a questionnaire and also follow up on their blood glucose. And once again, we found that there was a change in their sugar, and it's actually improvement in their blood glucose. And again, this is a non-intervention related study. So we find it really interesting. And we want to find out what are some of the components that actually help the patient improve their blood glucose. And we noticed that those patients who actually had their medications adjusted right before Ramadan tend to do better. Their blood glucose tends to improve for the better. And we found out that actually was something that made a difference for this group of patients. And surprisingly, it's not the type of anti-diabetic agent. It's actually the fact that the medication has been adjusted in prior to that. But of course, we see a lot of discrepancies in terms of the adjustment of medications because they're not really standardized. And then based on these two studies, we were able to get a grant from the Singapore government. And because of this particular grant, we managed to launch this clinical trial and run this randomized study, multicenter in nature as well. So that's really the history of why we decided to run this study, and because it's really the fact that there was a need from the very beginning. It's just that it was nothing has really been done it. There are some suggestions or guidelines from the IDF, for example, International Diabetes Federation, but the guidelines we are not very sure whether it's applicable to countries where Muslims are the minority, because the practice differences and the exposure differences. So we want to come up with something that is actually geared for the Muslim minority countries, and to see whether this particular algorithm can really benefit all.
You were trained in the U.S., right? As a PharmD. You were trained as a PharmD in the U.S.?
Yes, correct. I'm a PharmD. I graduated from UCSF, and then I did my pharmacy residency from University of Southern California. And then after that, I kind of took on this opportunity to work overseas. So that's where my career started off.
But most PharmDs and dietitians and physicians who are trained in the United States, if a patient came to them and said, I have type 2 diabetes and I want to fast for the next 30 days, they would just say no. What made you actually keep an open mind around that?
Well, I felt that when we take care of patients, I think in order for them to truly believe in their own care and then be able to be responsible for what they do, they have to believe in it. I think for the longest time, we've seen a lot of patients where they say that, we tell them what to do, and there's a gut feeling that tells us that they probably won't do it. And because they don't really believe in it, and for some reason, they don't think that's the way, they don't think they will work. And similar to the patients in Singapore as well, that they have to believe in what they do. And if religion is the reason for them to be good and to get their blood glucose control, then I think we should try to advocate and try to figure out, what actually we can do as healthcare professionals to help them. I think for every patient, the motivation for them to improve their conditions or to keep up with their conditions is really that they have something that they feel strongly about. I have some patients who actually use their vision a lot when they work, and when they start to have a burst of blurred visions where they have hyperglycemia, and so they start to worry about their vision. So, sometimes then we will use that as a way saying that, hey, the vision is important to you, then let's work on this, so that they have something as a motivating factor for them to actually make it happen. I think that's very important. And for the very devoted patients, if that's what they feel strongly about, then I think that is something that, I felt that maybe we can try to figure something out and then see if there's a way that we can help them fast safely. And some patients, we know that they're pretty independent, and they know when they have hypoglycemia. So some patients, I know definitely they can do it, even without the guidance. But other patients, they might need a little bit of support, encouragement, and a close follow-up with the healthcare professionals. And I think that after you've done it once, the next time and the following time, it will just be really much easier. So you just have to have that breakthrough point in the beginning, very beginning, for the first time. And then the latter part will actually run much easier. I mean, diabetes is chronic conditions, and there's no cure at this point. So we have to figure out a way to help the patients so that, they are motivated, they will continue to be motivated. And if religion is the way to go, then, we hope that we can help them still be able to practice what they feel strongly about, and then still stay safe, and try to use it as a more of a win-win situation rather than using it as a way to go against them. So that's something that I felt that we can do. Previously, I also came up with an algorithm called SIGN, and it's actually for patients who don't use SMBG and still want to get their blood glucose control. So I kind of have the experience of doing that, trying something that's not possible and make it happen. So I have right. So I actually have done that a different algorithm before, and it actually worked out pretty well.
So when you presented your algorithm to the dietitians and the other PharmDs and the clinicians that you were working with, how was it received in general?
So, of course, in the beginning, I was a little bit nervous, but they were very, very encouraging. They were more like, we actually have been waiting for something like this. It's just that they have been very, very busy. And me coming from a university, I really had the time to be able to actually practice this kind of more of a creative work. And so I said that, hey, this is a problem that we have identified. Would you be interested? So I approached endocrinologists in the beginning. Then I also approached the family physicians because I want people to know that you don't really need a specialist to be able to use this algorithm. Anybody with the training who actually see patients with diabetes are able to do it. So I involved endocrinologists, I involved family physicians, I involved clinical pharmacists as well as the nurse practitioners and the diabetes nurse educators to actually have them all come together to actually comment about this particular piece of work. So it took a while going back and forth, and also it was challenging for everyone to get together to make it work. But everybody was really, really enthusiastic. So, but they were also very careful. So I think based on what I initially suggested, they have lowered for example, the HbA1c cutoff a little bit than when I first suggested. So everyone was a little bit more careful. And then we actually launched a pilot. And when we did this pilot, we also looked into patients' perceptions to see how they feel about the user friendliness of the algorithm. And so we did this pilot study just to make sure things will work before we launched this randomized multicenter study.
And you talk about training the docs and the presumably the nurses and diabetes educators, et cetera. How did you train them?
Well, I think it was more of a mutual training. I wouldn't say I'm the only person who trained them. In fact, I really learned a lot from them, from my experience working with them. They actually have experience seeing patients who observe Ramadan, so who fast. So they actually have experience, and then they are also the members of people who conduct fast workshops before Ramadan. So this group of people, they're really the advocates of the patients who fast during Ramadan, and some of them also fast themselves. They also observe Ramadan. So they understand, how important it is to be able to practice the religion. And they actually offer this public workshop, education workshop. So if you refer to the algorithm, there is an education component where we ask everyone to attend this workshop, except for the patients in the intervention group, which is those who actually use the algorithm. We made it mandatory for them to attend the workshop. But the workshop itself talk about the medications, talk about what to do with the nutrition, what type of food to avoid and what not to avoid, how to manage hypoglycemia. So they do offer this kind of a general education workshop. So in a way, they are really knowledgeable as well, because I want to make sure when I approach people to help look through this algorithm, that people who are part of this basically advisory committee have experience seeing this type of patients. So they actually had a lot to contribute, and they were really very knowledgeable. But they may not be the whole. They may not represent the whole of Singapore, because after all, the Muslims are still the minority group. So, but they tend to see a lot more of those patients because they speak their language as well. They speak Malay. So, gotcha. But there are still a lot of other healthcare professionals, doctors, who may not have enough experience or exposure to this group of patients.
And you said that you have a telephone hotline where physicians who had concerns or questions could call?
Yes. This hotline is mainly for the patients, not so much of the physicians or the nurses. Yeah. So they will call and just to double check. But normally before they start observing Ramadan, we would have already kind of taught them pretty well. So it's more like just a reassurance for them, just to make sure that they're not so too anxious. Yeah. But in general, we didn't receive a lot of phone calls actually.
Okay.
Most of it, yeah.
That was my next question. Okay. And you talked about having people test their sugar 4 times a day, and adjusting their medications at home depending on what their results are. And you gave them the algorithm for that. Did anyone have trouble following that algorithm?
Surprisingly, no. They were able to follow it pretty well. So I think what we did was that when we actually have this separate worksheet where we actually write down all their medications that they're supposed to be using. So they have been that those are their own medications. So we would actually write down the instructions. So if they are taking 4 medications, then we will write down the instructions for that 4 medications. So on the algorithm, you will see all the drug classes, but they're not responsible for all the drug classes. They only are responsible for their own medications. So it actually makes things more focused for them. So they're actually able to follow the medication instructions pretty well. So, surprisingly, we actually didn't have anybody who had difficulties and end up with, complications. Everybody did very, very well. I think it's the confidence that the healthcare professionals, also the fact that they're being there and advocating them to do this, it gives them the certain, I guess, the encouragement to really to go ahead and do it, and then they're happy that their guidance and then they're helping hands behind the scenes if they really needed to. So I think that gives them a lot of encouragement to do it.
So one of the key components of the algorithm is switching from the premix insulin to a long-acting and then the rapid-acting insulin combination. And some people think that the reason people use the mix or use just long-acting alone is because it's just easier, less burdensome. But when you do the long-acting and the rapid-acting, if you do it right, you get a lot more flexibility in when you choose to eat. So
that's right.
The question for you is, how did patients and doctors and pharmacists and nurses think about making that switch to a more complicated regimen to allow that flexibility?
You mean to go from premixed to long-acting and basically 2 separate injections, right?
Yeah.
Okay. So, actually, we look at the premix differently because premix is really convenient, right? It's to provide patients with convenience and to provide patients with less number of injections. But at the same time, we also know that premix doesn't really follow the way how the physiological insulin needs is. So premix is probably only able to it provides certain it provides convenience for certain patients, but other patients where, say, for example, during this period of time where they need to be injected twice, because first of all, we will help them understand how the medication works. Okay, so, and we will tell them that if we increase this, then the other one also get increased, but you actually don't really need it. So they will understand. So then they will have to then they are convinced, then they will use the 2 separate injections. So patients in general, they are really willing to do this because their motivation of wanting to fast is very strong. So they also know that this is also a short-term period. So they actually don't mind to actually switch over during the short-term period of this 1 month. And then after that, they will actually convert back to their own, the premix.
Did everyone convert back?
Yes, everybody converted back. Yes.
Okay. And so I'd like to sort of shift the conversation. You did a lot of work with culturally tailored intervention here for patients of a specific ethnicity and language and a specific religion. But the idea that people with type 2 diabetes can fast is really kind of mind-blowing for a lot of physicians and dietitians who who see a lot of patients with diabetes.
Yeah.
Have you found that your ideas of how to help a patient fast have been applicable in other situations besides Ramadan fasting?
Yeah, actually, that's a very good question because nowadays we do talk about intermittent fasting to help lose weight and things like that. But majority of the data comes from patients people without any chronic diseases. And studies have shown that if intermittent fasting kind of help people who are at risk for diabetes. But when it comes to people with diabetes, meaning already being diagnosed with diabetes, I think the data is not very clear and it's actually very scarce. So, this particular study is not meant for, encouraging people to fast, encourage people with type 2 diabetes to fast, but it's more of following the people who actually practice Ramadan. Because when you breakfast and then when you start fasting, there is certain timing that we're talking about. So those adjustments is based on the timing of when you fast and when you break fast. But when it comes to people with type 2 diabetes and who want to fast, it may potentially work, but they need to be followed up very, very closely. And that needs to be careful because there could be a chance that there might be a sudden weight increase. We don't really know whether it would happen or not because everybody will fast differently. When it comes to Ramadan, it's quite clear how people fast. Right? So they break fast after sunset, and they start fasting again when the sun rises. But when it comes to intermittent fasting, that is not related to Ramadan. First of all, we have to find out when are you planning to fast and how long are you going to fast. So all this will make a difference in terms of how we advise the patient. So unless they're going to fast like certain hours of the day, then their medication needs to be adjusted. And also the timing needs to be adjusted based on when they plan to fast.
What you just said, that the medication needs to be adjusted based on how people are eating, really we've grown a system of medication and care for diabetics where instead people are asked to adjust their food to the timing of their medication. And that is a real burden for people, whether they're fasting or just trying to eat their, around their midnight work schedule or whatever it is, having them try and match their medicine with appropriate food rather than having the medicine match the food, it's complicated and it's burdensome for patients. And there's this guy, you probably know Victor Montori's work. Do you know who Victor Montori is?
No.
So Victor Montori wrote a bunch of papers about minimally invasive medical care, where he talks a lot. He's a fairly well-known diabetes researcher, and he talks a lot about making it easy for patients with diabetes to live the lives they want to live. So a lot of the ways that you talk about not ruining people's lives because they have diabetes, he talks about that quite a bit. And letting people make choices and empowering them to make the choices that work with their own lives. But he also wrote a book called Why We Revolt, which is a book about how patients don't always listen to their doctors because their doctors don't listen to them about what's important to them. And so, his idea is that we need to match the medicine to the patient's lifestyle, assuming it's a healthy lifestyle, not force patients to change their lifestyle to match the medicine. And I think that's a little bit of what you're getting across in your specific population, but I think it applies much more broadly and much more generally to everyone, that, we should be able to work the pharmacology out of these medications to the point where we can allow more flexibility and more choice. And I do think we're going to find that intermittent fasting, carb fasting, keto diets are becoming a more and more popular and more supported in the literature for people with type 2 diabetes or diabetes prevention efforts. We're going to see it. We're running some trials here at Michigan around that. Patients are doing it whether they're telling their doctors or not. And so I think it is the implication that you can adjust the medications to meet the needs of the patient around a period of fasting it is really innovative and really going to change the way we think about caring for diabetics more generally in the future, and also, pre-diabetics and people who are just trying to lose weight.
I think we always want to talk about individualized therapy, and rather than one size fits all, because we know already that does not work. And with diabetes, like I said earlier, that it's a chronic disease without cure. We need to find a way so that it can continue to motivate our patients to want to continue to be healthy, and not to feel depressed about the fact that they have a condition where there's no cure. When I see my patients, I always tell them that, having diabetes is not at the end of the world. In fact, we all are supposed to eat healthy anyway. Okay, so having diabetes gives you more reason to stay healthy. But if you monitor your blood glucose and you live healthy, you exercise and you stay active, there's no reason why they cannot get their conditions controlled. I always believe that we need to find the motivating factors, and I hope algorithms such as FAST can be a motivating factor. So in order for them to be eligible for this algorithm, they need to stay healthy and continue to be eligible, so that they will continue to be eligible for this particular algorithm. I strongly believe that individualized therapy is really the way to go, and I hope that as people live longer nowadays, we will definitely have more chronic diseases. And some people who are healthy, eventually they may also have diabetes, because we know that diabetes itself is also a disease of aging. When we get older, our insulin receptors tends to malfunction. So at a later stage in our life, if our insulin receptors don't work anymore, we probably will have glucose intolerance. But some people may not have it because they stayed active. So the message is such that we want to continue to individualize the therapy, and at the same time, healthcare professionals should find motivating factors to help their patients through their journey and different phases, through their journey of diabetes management, and also different phases of diabetes. So I will always say, don't let diabetes take over you. Take over diabetes and show who's the boss. Right?
Have you ever used continuous glucose monitoring with any of these patients who are fasting?
That's a really, really good question. In fact, we tried on 10 patients for this study. Our grant was not big enough. I wanted it to, actually. I really, really wanted to. But the funding was not enough, so I couldn't do it. But I managed to have funding for 10 patients. 10 patients doesn't really tell you a lot, but we are actually looking into those data right now.
And did it seem like it was easier, harder, or about the same as 4 times a day testing?
It's definitely easier, because a lot of people who are praying, they don't really want to stop and then prick themselves. And so if we have this CGM that we talked about, it actually would be much better, and it will make your life easier. So some of the brands, I won't mention them, but you probably know which one I'm talking about, where they can just kind of, put the glucometer or their phone next to the port, and then they can just get their sugar. That's really probably the most ideal way to go, and to make things much even easier. Because sometimes when they're praying, they're so focused, and it's not very convenient to take out glucose meter and then start to prick and trying to find out their blood glucose. But nevertheless, a lot of people were very enthusiastic about it because they just like the fact that there is an empowered system to help them, to allow them to fast.
Well, that's all my questions. Is there anything else that you wanted us to know about how the study went, or what you think is your next step, or where this is going?
Yeah. Well, I think for the future step, what I want to see is that I want it to be used more broadly in the Muslim minority countries, because this algorithm is really specifically dedicated for places where the healthcare professionals may not have enough exposure to this kind of group of patients. So if we can actually have this tool being used by the Muslim minority countries, I think that would be something that we really want to see whether it will work or not to bring to the next step. But in order for more people to use it, I think another plan that I also have, and I hope it would happen, is to make into probably some app, like maybe a phone app, where it's more user friendly. Where say the doctors just need to put in patients' anti-diabetic agents, and then say how it's supposed to be converted. If we actually can have such an app, it will improve user friendliness, and more people will be more willing to use it, to look into it, and also for the patients too. Then they just need to put in, their sugar right now, and then so what do they need to do based on the plan, and then the app will just calculate for them. I think that kind of app would be really useful, and it will also be a way to really for more people to get to know this algorithm.
I'm wondering if the one of the continuous glucose monitor companies might put something like that together just for people who are fasting for a month, just specifically for that.
Yeah. I think that would be something that they should invest.